Over to you, Dr. Seth and Dr. Garimich and Sridhar.
Thank you very much. I think we're ready to move in the interest of time, so we should go on to the first live case. Welcome to my co-chairpersons, and really it's great to see Gary as well as Sridhar with these, whose comments would be so valuable in this session on imaging and optimization.
Hello, good evening. It's a wonderful working evening at Apollo Bangalore. Thanks for giving us an opportunity to come and share our work with you. I thank the organizing secretary and the chairpersons for today, Gary Mintz, Ashok Seth, and Dr. Sridhar Kasturi. Sir, Dr. Seth has been a father figure for us. We've seen how to twist catheters from you and my good colleagues, Dr. Ajay Swami, Rajnish Kapoor, and Dr. Arneja. Here at Bangalore, we have a team. Can you just show? My colleague, Dr. Praneeth, Dr. Venkatesh, cardiologist, and my techs, Mr. Sakaria and Mr. Ketan, Mr. Pandu, and my colleague anesthetist, Dr. Mahalings. Here we would be showing you a case of a young lady, just 55 years old, but very calcified disease. It's a 57 years old female, had a typical angina, crescendo for last 10 days, rest angina for last 2 days. ECG was sinus rhythm with ST depression in inferolateral leads, echo, no regional wall abnormality, good LVEF 60%. Diabetic and hypertension for 10 years. Can we just play? This is the right coronary artery. Very diffuse disease in the freeze, please. Very diffuse disease in the PDA. The proximal, angiogram was done elsewhere and they reported a 60-70%. Go to the left side. These are the left injections. There's a very critical lesion in the obtuse marginal, and then the osteoproximal circumflex is densely calcified and diseased. And same with LAD. Can you go to the cranial views? Yes. Yes. You can see here, it's a very diffuse disease, and surgeons thought it's prudent not to do the surgery, and if we could do something percutaneously. And that was the plan. If I may ask the chairs, how do we proceed? Our plan was to do an FFR for the RCA, just to know whether it is significant or not, and we did one. Can we just show the FFR? And it was 0.97, insignificant proximally, and we thought the PDA, if at all symptomatic, will deal later, and we moved on to the left side. Yes, can we play the caudal freeze? This is the angiogram. So there is disease in the distal LAD, looks pretty calcified. The OM is very, very critical, and the osteoproximal circumflex is very densely calcified and, moderate to severe disease. Going forward, the whole outcome depends on how well you understand the disease in the wall, rather than just the final results we may achieve by implanting a stent. And that's where imaging is so crucial. And imaging has brought such a great understanding to the disease and the plaque modification that you can very wisely choose whether you want atherectomy, you want OPN balloons, or you want shock wave, or you can do away with none of these. So here we had the privilege of doing an OCT. Can we play the OCT? Sorry, before doing the OCT, we knew that it wouldn't cross that critical lesion in OM. We dilated that lesion with a 2.5 millimeter balloon. Can you go ahead, please? Next with the balloon. Yeah. This was pre-dilated with 2.5 millimeter, expanded easily at about 12 atmosphere pressure, NC balloon, 2.5, next. And then we ran an OCT. Can we play the OCT, please? Yeah, it's about 2.3 millimeter distally, Yes, freeze whenever you see, yeah. Go back. Yes, after the dilation, this is the distal lesion which was dilated. There is still calcium between 6 to 10 and then keep coming in. Yes, pretty narrow, you can see dissections. Keep coming in. Right. Okay, that's the broadest space and then keep coming back. Right. You can see the dense calcium, pretty eccentric between 6 and 10. Next. As we come in, it almost encircles. Come in. Yeah. Come in, please. Yes. This is the ostium of the circumflex, almost 300 degree of calcium, right from, about 5 o'clock to 1 o'clock. And this is the, entry of the circumflex into the left main. Again, it's pretty circumferential. This adds a lot of clarity to how we deal with this plaque before you implant a stent. And left main, you can see here, between 3 and 7, again, there is a significant amount of calcium with lipid-rich plaque. And it's about 4.5 millimeter in diameter. Yeah, that's the calcium. Come back. Okay, can you go to the LAD? And we also did the OCT of the LAD. We didn't expect anything less looking at the circumflex. You can see here completely encased vessel, completely. And the thickness of the calcium is up to 1 millimeter, 1000 microns, more than 1000 in fact. And it's not focal. For a significant length of LAD, the disease is as this. This is the osteoproximal LAD. You can again see about 300 degrees from 12 o'clock to about 9 o'clock. And that's the ostium, very densely calcified. It's about 3.25 millimeter LAD, fully encased. Come back into the left main. Good. Thank you. So, I pause here and ask for your comments. Dr.
So I
Seth?
think I would then pass it on to the panelists. I think they should be able to comment on this. So Dr. Mahesh and I think Dr. Swami is also there. So Mahesh, why don't you say that? And I would want you to carry on, by the way, also, because unfortunately for this highly complex case, you have 30 minutes. So I'll let you proceed while Dr. Mahesh answers.
Thank you.
The problem seems to be calcium, and the calcium from the 2.5 balloon, the way it behaved, it didn't seem to be very difficult to get through that calcium in the first place.
Right.
So probably I would just go ahead and do a multiple dilatations, probably with the non-compliant balloon, and then see how the calcium is behaved, and then decide what should be done with the further thing. The LED looks extremely complex. It is diffuse, and no wonder the surgeons gave it.
Sure.
I think
that's
you
good.
tackle lesion by lesion again with pre-dilatation, and then decide whether you will go in for an IVL or whether you go in for an OPN balloon in this.
Yeah. Okay. Let me
So
tell
Sridhar,
you.
yourself.
Sorry. Let me tell you what I did, because
go
I have a
ahead, please.
balloon across the circ ostium. We wanted to do a left main bifurcation, but implanted a stent in the distal LAD. We used just OPN 2, 20, and then another 3 into 12. And to our surprise, we got a great lumen, great cuts. Can you just show the OCT after the distal dilatations? Just short of time, so I'm just running through this.
You're going to go, and I'll just comment on the fact that the big issues here are the osteas, where there's a 360-degree calcification. Osteas of the circumflex behave very badly with balloon dilatations.
I pulled it back.
So that's one aspect, deep calcification, and the second is landing zones, which you don't have in the LAD very clearly. So this is going to be interesting. But my clear observation would be that I would actually do a shock wave to the osteas very clearly, which means I would do shock wave along the length of the lesion, because for me, osteas are the most important.
Thank you. Now we are at that point where we have taken a shock wave first into the circ ostium. Cine. That's a 3 millimeter, slightly down. Can I just see?
Highly
First-
complex. I must tell you, you're doing a
Thank
great
you.
job. It's a highly complex case.
Thank you. Just go ahead. So we're going to start inflating at about 4 atmosphere. This is a technology where the contrast and saline mix with the impulse produces small sparks which cause sudden formation of air bubble and shock waves. At about 50 atmosphere, it affects the wall. Okay, we gave 10 pulses and this is how it looks. Can we come back? Deflate. Deflate. Okay, wait. Pressure is coming down. Can I give a Frenin, please? Quick. Frenin? Yeah. Frenin? Good. All right. Get the pressure up. Okay, pressure is getting better. Can I have one injection just to see? Okay, doesn't change much. Can we go again? Another set of pulse. Keep the Frenin ready. Go second 4 atmosphere again. Balloon expands slightly better than the first time. We have started the impulses. This is the second cycle of 10 impulses.
Can we see the fluoro, please?
Fluoro, yes. Yeah, stop. Wait for the signal, therapy signal to switch from orange to green before you deflate. Frenin, please, again. Green. Deflate. Deflate. Okay, we are done. I think we need to accept it for now because of the hemodynamics, and we will check again. I would use half the pulse here and half for the LAD ostia because both are about 3 millimeter.
So the comments I have on this is that once you don't see an expansion of the balloon, you should deliver all the pulses here because again, you're not doing an adequate job. You will then take a different balloon for the LAD,
Right.
but it's still wise to deliver as many pulses which will
As
get you the
possible.
maximum expansion.
Okay. Go again. We're going.
If I can make one comment, there is an upper limit in calcium thickness that the shockwave device will impact. And some of this calcium is more than a millimeter. And that's probably the upper limit.
Right. Looking at the ease with which deflate. Looking at the ease with which I could, open the LAD, which was circumferentially calcified with the help of OPN, I would like to try and save these for the LAD ostial. I don't know how appropriate it is.
Good evening, Girish. One comment from me.
Dr. Sridhar, thank
Good
you.
evening, Dr. Ashok Sesar and Dr. Means. Actually, when you are doing the LM bifurcation, there are some studies where you can put NC into the LAD ostium and IVL balloon into the LCX ostium. Simultaneously, you deliver the pulses to the LCX balloon. Most of the time, those pulses are also transmitted to
275
LAD.
OPN.
So that time you can give a more effective pulses. Subsequently, you give a additional pulses to LAD. If this, because compared to LCX, which is a focal, the length of the calcium appears to be less than 5 mm, whereas LAD diffusely
want to
calcified.
3.2,
The requirement
2.5, get me
of
another.
IVL more for LAD, and as Dr. Ashok said pointed out, the most common site of under-expansion LM bifurcation is LCX ostium, seen in 35% of patients. Still, IVL is not behaving properly, and that block modification is not adequate. You may require some plot modification. If you take the OCT also, if the OCT shows the fractures, that is adequate. Are you doing the imaging again after this one?
Yes, I would do an OPN again, 2.5, and then do an imaging to know should I have to exhaust my pulses here and take another one for LAD.
We won't want to interrupt you. So we would have a discussion amongst ourselves while you do these changes, etc. So please continue coolly because it's a complex case.
Thank you, sir.
So Sridhar, and this is again, are the other panelists here? Because I don't
ECG?
see them. Who else is in the panel? Swami, are you there? No. So we had Mahesh and Dr. Rajneesh was supposed to be there. Is he there? Okay, then we should have a discussion. Gary, I think that was a great comment around the one, your 1 millimeter comment around that. But I don't think, we're looking at that, are we? We're looking at the point that there could be softening of the plaque at multiple areas where it could be thinner than 1 millimeter, and therefore we would get adequate expansion, maybe elliptical, but certainly adequate lumen in that area. Your comments around that. So we're not looking necessarily at that 1 millimeter point or 1.5, but in the deep calcification, we'll have cracks, fissures, or softening without cracks and fissures, but would actually lead to an expansion.
Yeah, I mean, it's entirely possible. My impression of the two vessels is that the LAD was essentially circumferentially calcified over its entire length with varying thickness. Yeah. And the circumflex was spotty calcium. But you're still dealing...
Apart from the ostium.
Right. The ostium was the worst. And the ostium, of course, has multiple issues because even if the ostium, the circumflex was not calcified, you still often struggle to get a decent acute result. And sometimes, with a case like this, there is no perfect solution. And sometimes you try one thing, you try the one that you have the best hope for success and the smallest likelihood of complications. Yeah. And if that doesn't work, you then stop, you rethink, and you go to a second option. But these, particularly the LAD, I look at this and I'm just, I don't quite understand why a 57-year-old woman would have this kind of LAD. Granted, she's diabetic, but unless she has something else going on, this is really quite unusual.
Gary, this is India. Welcome to
I know, but still.
We see a lot of this. We see enough of this. I mean, I would say a lot. I would say, none of us are surprised about it. That's all.
Yeah. I mean, I'll tell you, the other place you see a lot of this is in Taiwan for some reason that I don't totally understand.
Right. May I just have a comment? And Sridhar, this is also in relationship. You see the circumflex. If I would have actually rotablated the circumflex ostia, because if it's circumferential, then I know that the guide wire bias gets me a good deep cut. And then the IVL, which is more opposed to the deep calcification, where preferential cuts may happen. And specifically at the circumflex ostia, you get a bigger lumen because of the guide wire bias. And then it actually expands extremely well. So for the circumflex ostia, I would do a rotablator followed by an IVL. And I would take another IVL for the LAD, because we must remember the ostia of the LAD could be 3.5. We don't want to undersize that. That's probably the most important area. So I'd actually do the proximal LAD with the IVL. But I think this case requires 2 IVLs. And unfortunately, because of the expense of IVL, we always seem to ration it out. And rationing means that then we have to end up doing non-compliant high pressure balloon dilatations or an OPN balloon dilatation to get an adequate expansion.
Yeah, I mean, this is not a case where I'd ration the impulses.
Yeah.
So, but the calcium is quite deep-seated, and there was hardly superficial calcium, even if the ostium of the circumflex. How effective you think the rota would be?
I'm saying rota plus IV. You don't. So rotablator gets you eccentrically larger lumen so that your balloon opposes the calcium much better, and therefore you actually are able to fracture even deeper calcification because you're closer to the calcium now than you were to start off without any rotational arthritis.
And the choice of wire also has to be very carefully chosen in these cases because you're using OPN and IVL. If you choose a hydrophilic wire, probably it will come out along with the balloons. They get stuck very badly.
Yeah.
Ashok, this is Ramesh Dagubati. I'm sorry I joined a little bit late. Actually, I just observed. I just want to make one comment. I think in shockwave, I saw Girish actually going up to 4 and delivering the pulses and then deflating it. Normally, in our practice, at least, we would go up to 7 or 8 and see if it expands well.
Okay.
I think he did go up to 6. I think he did go up to 6 after. That's our practice.
Right.
That after 4 delivering, he would go up to 6 and deflate.
Right. If that was the case, then we did not see actually the balloon expanding. So I would definitely deliver all the impulses, all the pulses right here. Yeah.
So, Dr. Navasundi, where are you at this time? We've been having some discussions, but not to disturb you.
Great learning. We dilated initially with 2.5 OPN and then 3 OPN. And we are taking an OCT. You can have a live OCT. Can you show live? Ready? Start. Okay. I see a fair-sized lesion. I'm confident that if I implant a stent, I can post-dilate it to a good size.
So 3 to what atmospheres with the OPN ultra high pressure balloon?
I went up to 30.
Okay, 30. And did you get an expansion of the 3?
Can I show you the cine? Can you show the cine, please with 3?
Please do.
Show the 3 previous to this. This was OCT. Go back. Go back. 3. Yes. This is the balloon 3 OPN at 30 atmosphere. It looks fairly expanded, maybe eccentric dilatation, but seems a decent volume of lumen.
It does.
Thank you. So can we have a look at the OCT? Are you able to see the OCT?
Yeah.
Thank you. So this is the circumflex OM. We are coming into that lesion. Come back. Yes. Yes. This is well cracked, but still there's narrowing, but not too much calcium though. Come up, please. Come back. Yeah. There are multiple cracks. Lumen is acceptable. Come back. Come to the ostium primarily.
Yeah, because you only worked at the ostium at the moment.
Right.
And so
come back to the ostium.
Yeah. And you.
There's some hematoma. Come back. Yeah, come back. The lumen is not too much, but there are cracks.
But if you go distally slightly, we saw
slightly
cracks.
distal.
Gary, you just saw that cracks. Distally.
So there are cracks in the calcium. Right. There's a pretty good sized dissection, and there's a pretty large intramural hematoma.
So I think we will go to LAD now and then try to do the shock wave and then do the stent of the circumflex followed by left main to LAD.
So what strategy of bifurcation are you intending to use? Mini crush?
I think I would do a DK because there is so much calcium. I don't mind little more at the edge of the left main, but I don't want to miss it. So I may prefer a DK crush.
Yeah, but the DK crush has also evolved into mini crush.
Yes, sir.
It's no more 3 millimeters and 4 millimeters. It's 1 or 2 millimeters.
1 or 2 millimeters. I think that is what I would do. How many? We have another 5 cycles remaining with us. You know,
so just while you carry on again, just want again the audience to start understanding that he's using that at 30. So if we actually got a complete expansion of the IVL, think that we won't have to use ultra high pressure or even high pressure. We can use moderate pressures and still get a good lumen and a good result. But if we're rationing, and that is one of the critiques which happens saying, but after IVL, you don't need to do ultra high pressure balloon. But it's not just that. In real life, where you have deep and very thick calcification, like Gary pointed out, where you have inadequate pulses because you're rationing pulses in multivessel disease, where you got long lesions where distally would be a 3 millimeter IVL, but proximally that same 3 millimeters being used where it should be 3.5, then you would have to resort to high pressure, non-compliant balloon dilatation post-IVL. And in this case, I would use OPN because it's the safest non-compliant balloon. I hope everybody's understanding that. If you use non-compliant balloon to 25
From the
atmosphere,
left main,
that's unsafe compared to an IVL at 35, compared to an OPN at 30 atmospheres. Because OPN doesn't expand, it expands minimally.
okay, I think it will deliver here. 2 pulses, go.
So I'm sure
Start.
Navasundi, you heard those comments.
Yes, sir, we did. Now we are going at 6 atmosphere. The next cycle, wherever there was significant calcium, balloon seems to be pretty expanded. Okay, we finished
Look
one
at that
cycle.
calcium on the top. You see that eccentricity of thick? That's the thickest part of the calcium.
Very
and
true.
that's why you see the eccentricity on the top itself.
So we
Deliver
will,
more pulses. Keep 2 or 3 pulses for the ostia. I think you deliver 1 more and then more for the ostia.
yes,
Ostia
sure.
needs the best.
I think this is where I need the most. I will exhaust them here. Go. 6, 6. Yeah, go 6. You can see it's fairly expanded. Okay, come back. Okay, we'll go another cycle, stop. Okay, deflate. Front in, please. Given, thank you. And it's strange, so much calcium, but not troubling too much. We would only know, only after implanting the stent, the final picture. Okay, wait, let the pressure go up. Yeah. Now, can we go again?
One of the most important comments here is this case should never be done without an imaging. You owe it to the patient, not just to do a good job, but to give him the best outcomes. Any complex, severe calcified stenosis should always be imaged. And I don't necessarily say that for mild to moderate calcification. That's a usual part of our lives. We see that increasingly.
Thank you.
But any complex lesion needs optimization for the best possible long-term result.
Front in.
But despite so much of calcium being there in the ostium and the LED, you see the IVL balloon just went through. It didn't create too much.
Remember, he's pre-dilated that.
Yeah, with an OPN 3.
In the LED?
In the LED too. Okay.
No, IVL would not traverse that calcification very easily.
I did, sir. Can you just show the IVL dilatation 3 of the mid LED?
So, you did a good job.
Thank you. Okay, can we go again? Pressures are better. Okay, now get me a 28 stent. Go, 6 atmosphere. Yeah, this is the most.
And now you finish your pulses.
I think it's expanding fairly well.
Yeah, reasonably well.
Front end, please. One more.
Sridhar, your learnings from you.
Very, very.
You're done.
Actually,
I know. Pressures. I want to wait.
First, assess the block. What is the block? Calcium extent, length, circumference, and those things you have to assess. Once you do the effective block modification, it's important to see that adequate dissections are.
Can I do the imaging? One more is there.
Calcium plate fracture, very important. If the plate, if the calcium plate fractures are seen, Kubo has described very
clearly. Be ready with framing when I ask.
Is reduced drastically from 14% to 41%. So that's the reason it's important to see that effective fractures in the calcium. Is it there or not? If the calcium fractures are there, that time you implant.
OCT, please.
Once you understand,
adequately. Sridhar, I think I'm just going to stop you here because I'm going to make a statement and then we're going to actually get Gary in. You said that we need to see fractures and it's very important.
This.
Yeah.
I'm actually telling you that certainly for IVL, the data tells us, at least for CAD3, that nearly 30% fractures were not even seen. And yet there was no difference in the lumen achieved after stent implantation in those who had fractures and those didn't have fractures. And that was a 100-patient OCT study. I don't believe you need to see those fractures, at least for IVL. I think you're overdoing it. There are numerous mechanisms of softening plaque. Fracture is only one of them. You may have microfractures which cannot be seen by OCT. You may have other mechanisms which actually you don't know. So Gary, I want you to comment on seeing fractures being very important.
First of all, the Kubo study was only balloon angioplasty,
Correct.
Nothing else. The mistake that people make, and I don't have a solution for this, but the mistake is to assume that all calcium is the same. It's not. Some calcium is harder than others. The superficial calcium tends to be harder, and then underneath that, the calcium tends to be less hard to dilate. And at the end of the day, what's important is the minimal stent area and stent expansion and how you get there. We've known for a long time that even though rotational atherectomy, for example, does not change the arc of calcium and you don't see fractures after rotational atherectomy, the stents expand a lot easier. So, you know, sometimes you just have to take what the techniques give you, make sure that your pre-dilating balloon can be fully expanded before you place a stent, have your tools available to work the stent after it's implanted to achieve the minimal stent area. But if you don't have fractures, it doesn't mean you stop. It means that you sort of shift your strategy a little bit. And you recognize, as Ashok said, you won't get these giant fractures 100% of the time. It's nice if you see them, because then you know you're basically done. But that doesn't mean...
Yeah, okay, sir. Usually fractures are not visible. That means we have to take like an open NC or take high pressure NC, see that, because that is not adequate. The rota, sometimes it can shave the luminal area, maybe increase, or it may cause the fractures, or it's only plaque modification. That time still, if inadequate, if you don't see adequate fractures, take high pressure NC balloon dilatation or take the open NC. Otherwise, put the stent, post stent, you can put the open NC and expand it further. Ultimately, the single most predictor of the ISR is the under expansion.
Okay.
Correct.
Give me a 3 mm balloon in LED.
So I think I'm going modifying your answer to saying what is most important is that do not implant a stent till your balloon is fully dilated. Yeah. And your biggest predictor of stent under expansion is after IVL, post balloon dilatation.
Yes.
Before you implant a stent. Not fractures, but post balloon dilatation. And I think that I want to convey to the audience.
Yes.
And by the way, that's been true for what, 20 years?
Yes, yes, Gary. We've learned that even before the days of any of these, apart from rotational atherectomy and everything else.
Back.
I mean, the interesting aspect is calcified lesions are being done for the last 30 years.
3
mm
mm balloon here.
Certainly.
It will not go. OPN will not go.
But we have just more tools. And
if
more
I may interrupt, sir, wonderful discussion. We have done the OCT for the LED after OPN and IVL. Would you like to have a look?
Please go ahead.
Start from inside the stent.
Go Dr. inside Srinivas, the stent. You're going to tell us when to stop, because then we can go on to the next case and come back for this final result of now Dr. Navasundi.
If you could look here, this is the distal stent. Could you just see the diameter? What does it look like? Freeze.
4.9.
Okay. Look at the length of the diameter here, please. Can you see? 2.75. Actually, I dilated with 3, but even then I've got achieved 2.75. And now we have used IVL here. Come back into the proximal to mid to proximal LAD. Although it's a circumferential calcium, this is how it's broken. You can see. Not all over, maybe at certain places. Next, keep coming. Yeah. There are big cuts and hematoma is also seen. Yeah. Come back, please. Come back fast. Yeah. You can. It is lumen. What is the diameter? Is something like 2.65. Come back. Come back. Yeah. Now there's a good cut here at 6 o'clock. Come. Not as obvious as a cutting balloon, but lumen looks good. Come to the ostium, if you don't mind. Yeah. I think here, although There are good cuts in the calcium. You can see both 6 o'clock and 12 o'clock. There are good cuts. Come back.
No, sorry. The 12 o'clock is the wire.
No. Can you show that? Yes. Just next to the wire. Can we see
Yes,
that?
actually.
Yeah,
Yeah,
we saw that.
tiny one.
There's a small one next to the wire.
Very true. Thank you. Now we intend to stent. I will probably park a balloon, 3 balloon in the LAD and stent the circumflex first. 3.25, that balloon is here, no?
Dr. Seth, sorry to interrupt. I'm Dr. Srinivas Kumar here.
Yes.
You have shown excellent bed preparation and very good OCT pictures of how the calcium gets cracked and all, but we have exceeded time. Girish,
Sorry.
we'll come back to you. We'll go to Chandigarh and the last 5-10 minutes we'll come back to see your final
Last 5
result.
minutes to see the final
Okay.
result.
Thank you. Have a wonderful
Thank
evening.
you. And
Do a great job. You're doing very well, extremely well.
Thank you.
Thank you.
Yeah, you're audible, Girish.
Thank you, Dr. Srinivas. And to come back, let me just show you what we did. Show the circumflex stenting, please. Come back. We use a 275/28 Zions expedition into the circumflex position. Go back and show the position eleocaudal. Okay. This is a mini crush. Keep play.
Yeah, I heard
Freeze.
many.
Next view, please. Yeah. This is where the circumflex stent inflated. Next. Inflate. Next. Yes. Next. And we post dilated with a 3 OPN, the proximal part, at 30 atmospheres. This is the OPN. Next. Okay. And then we crushed that stent, recrossed, and this was a first case. Next. And then we pre-dilated that LAD again with 3.25 NC 12. Next. And can you freeze? Can you have a look at that circosteum? Zoom, come back, one frame back. Yeah, zoom it, please. Can you see the circosteum? I think it looks fairly expanded. Come down, please, the other direction. Yes, frame by frame.
Okay, you'll have to move
Next,
ahead
next.
because
And
you'll have to look at your final result.
thank you. And then you have the LAD stent. We use a 38 Zions expedition 3.5. Next. You can see, come back, yeah. You can see the expansion of the ostial LAD. Looks fairly all right on the stent itself. Next. And then again we post dilate. First we did the pot 4.5. Next. Go forward fast. That was the, and then we did the 3.5 in LAD. And we are at this next. Now we are at this. We are just recrossing into the circumflex and doing the final pot.
So proximal crossing or mid crossing, but not distal crossing.
Right.
So
Did
you
it?
just cross distally.
I will come back for you. How do you think this is, sir?
I think you've done a great job.
Yeah,
I think you've done
thank
a great job. I think this is commendable. This is a very difficult case, and you've just done it marvelously, and you've done it with good imaging. And I think we've learned a lot from this. So it's going to be mid, so that to redistribute carina, I'd not even go proximal. I'll just go mid, redistribute carina
Yes.
on both sides, have less of carina, or have less of metallic carina, and therefore, and do a final pot and just do imaging. And I think that's great. Keep in mind that it's a 2.75 and a 3.5 fractal anatomy. There would be probably 4.5 or slightly larger, but then we leave it to Navasundi to actually complete a great result.
Thank you. You made our day, sir.
Thank you, Girish, for excellent demonstration, and thank you, Seth, sir, for concluding.
Namaste. I am Dr. A. Srinivas Kumar, Senior Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. We are very happy to bring to you the live case learning series of videos. This video brings best wishes from Fax Foundation and TCT India South Asia Conference. We wish to bring to you an interesting live case demonstration of calcific left main plus triple vessel disease in a relatively younger patient, and it was effectively tackled by OCT guidance and bed preparation by OPN and IVL balloons, followed by stenting later. This was done by Dr. Girish Navasundi from Apollo Hospitals, Bangalore. What we have seen in this relatively young lady was triple vessel disease. RCA did not have much of a disease. Borderline disease, FFR was done, which was shown to be negative. So RCA was left alone. Coming to the left system had very critical diseases, especially in the ostial LCX and the proximal LCX portions. And then LAD also had critical stenosis in the mid LAD and probably moderate to severe disease in the ostium LAD, and the calcium was extending into the left main. So initially what was thought and decided was to do little balloon dilatations with 2.5 mm balloon so that OCT catheter could go and from through that critical disease. So initial NC balloon dilatations, after doing it, they were crossed relatively easier, though calcification appearance was very significant. Then OCT catheter imaging was done, initially in the LCX and then later on in the LAD to left main. Excellent demonstration of calcium, extent of calcium, the depth of calcium was very well highlighted by these excellent OCT pictures which are obtained. Thanks to technology, we are going to the extent of precision, millimeter by millimeter depth assessment, and if it is more than 1 mm, that's what it becomes very important, significant, and more deeper the calcium, and the more the extent of the length of the calcium, and more the circumferential nature of calcium, the more difficult it becomes. And probably we need to more and more superior advanced technologies like IVL to tackle such case scenarios. And whereas if a patient has only mild calcium and thin rim of calciums, we could get away by doing NC balloon dilatations. And somewhere in between ranges, probably we could take the help of OPN balloon dilatations. That's how I think decision-making process in the bed preparation goes. But here I think we had to use experience and expertise of both technologies together, because in spite of using IVL balloon with multiple pulses also, still significant residual narrowings were remaining. That's how again Dr. Girish used OPN balloon dilatations over IVL. Dr. Seth was thinking that probably procedure before superficial run of rotablation also could have made the disease area opening eccentric and probably could yield to a better area and better dilatations and better initial area openings. But here Girish used IVL followed by OPN, and which again after that OCT imaging showed excellent ways how that balloons and OPNs and IVL worked. We could demonstrate cracks in various places and various types of dissection appearances. It was also highlighted that sometimes even the CAD disrupt the CAD data and others, we may not have obvious ruptures seen, but still the calcium gets loosened and the areas increase. These aspects were seen, but if you definitely find evidence of cracks and calcium ruptures, that means the artery has opened up well. And bed calculation after the bed preparations, then those lesions were initially again stented. And regarding the mid LAD, after doing it, then both ostial LAD, ostial LCX, and the left main was managed by DK crush technique, because the disease was significant and highly calcific. So optimal expansion of both with again followed by stents in those areas rather than provisional was thought to be very necessary and essential in this calcific vessel disease. And after initial aggressive balloon dilatations and then probably ostial LCX with minimal protrusion again of the stent, the LCX was done. The later again left main to LAD stenting was done. Then initial DK crush technique steps were demonstrated. Then after stenting again, finally it was recrossed and again final kiss and the final part was done. showing effectively a good result and outcome. And the OCT demonstrated excellently the proper apposition of stents and expansion of the stents in this difficult subset of patient with very significant calcific left main and triple vessel disease. I think thanks to technology, thanks to OPN, thanks to IVL, we could crack such significantly calcific vessels, and thanks to imaging technology, we could assess whether the outcome bed preparation is done properly or not. Thanks to latest generation, third generation stents with thin struts, which could go into such difficult lesions and expand well and give proper immediate post-procedure outcomes. And again, when the initial results are good, the long-term results of the patients will be good, and probably if the patient maintains the lifestyle and take all the medication advised regularly with high-dose statin and antiplatelets, all these such difficult anatomy patients where the surgeons also felt that the grafting could become difficult because of calcifications, could be effectively managed by percutaneous PCI techniques. And such things were excellently demonstrated by OCT guidance and the proper teamwork by Dr. Girish. Congratulations to all the team, and hope all of you enjoyed this OCT demonstration of calcium, how the calcium's cracked, and how the OPN and IVL's inflations to be done, and then final outcomes, how it could be positively influenced by such technology. Thank you all, and this is Dr. A. Srinivas Kumar. Thank you.